Good morning and afternoon, wherever you're joining us from today. My name is Innes Taylor. I'm one of the co-founders and directors of Safe Obstetric Systems. We are the makers of the Fetal Pillow, and welcome to our first ever webinar, where we will get into what the Fetal Pillow is, hear the latest clinical research on its use conducted at the Brigham and Women's Hospital in Boston, Massachusetts, followed by a discussion on full dilation cesarean sections and the role of the fetal pillow. We will be joined by a distinguished panel of speakers, including Dr. Sarah Lassey, Dr. James Greenberg, and Dr. Julian Robinson, all from the Brigham and Women's team, and from Dr. Rajiv Varma, the founder and inventor of the fetal pillow. I would first like to introduce you to Dr. Rajiv Varma, an obstetrician and gynecologist for over 30 years in the UK, and founder and inventor of the fetal pillow. He will discuss what the fetal pillow is and how it works. Dr. Varma?
Hello, my name is Rajiv Varma. I'm the inventor of Fetal Pillow, a device that is used in full dilation cesarean section with a deeply engaged head. The idea of the device was conceived a few years ago when we lost a baby in our hospital, when a cesarean section was being performed at full dilation, and due to difficulties in delivering the head, hand from below was used, which resulted in severe trauma to the fetal skull and sad demise of this baby. At that stage, I started thinking if you could create a simple device that could elevate the fetal head before performing the cesarean section. And this is when I came up with the idea of Fetal Pillow. As you can see, it's a small device which is inserted prior to performing the cesarean section. It is then inflated using 180 cc of fluid, which elevates the head 3 to 4 centimeters. All the trials and user data have consistently shown reduced complications for the mother, particularly the extension of uterine incisions and the blood loss. It makes the delivery easier.
Thank you for that introduction to the fetal pillow, Dr. Varma. Next, I'm delighted to have Dr. Sarah Lassey from the Brigham and Women's Hospital, who will present their double-blinded randomized control trial that was published in the Green Journal earlier this year. Thank you, Dr. Sarah Lassey.
Good afternoon. My name is Sarah Lassey, and I'm an attending in maternal fetal medicine at Brigham and Women's Hospital, here to talk to you today about our experience with the fetal pillow when we performed a randomized control trial. As you all know, arrest disorders can affect up to 20% of labors and are a common indication for cesarean delivery. And these deliveries can often be difficult, especially when they're for failure to progress, due to the need for additional procedures to deliver the fetal head. And as a result, these deliveries are associated with an increased risk of maternal and fetal morbidity, including uterine hysterotomy extensions, increased blood loss, and neonatal injury such as skull fracture. The fetal pillow is a balloon cephalic elevation device that's designed to elevate a deeply impacted fetal head atraumatically out of the pelvis during a second stage arrest. It's inserted in the vagina and placed beneath the fetal head to help lift the head from the pelvis. Once it's inserted, the patient's legs are laid flat on the operating room table and the procedure is performed. It's been associated with a reduced risk of major hysterotomy extension. And in prior literature, there was a decrease in hysterotomy extension from 15% with a hand from below compared to 4% with the fetal pillow. And an RCT that was previously performed showed a reduction from 32.5 to 5% in hysterotomy extension. As a result, it was cleared by the FDA in 2015 for use in women who were at least 37 weeks gestation and required cesarean delivery at full dilatation. Our study was a double-blinded, randomized controlled trial at a single tertiary care center. And the purpose of our study was to evaluate whether the fetal pillow reduced time to delivery after hysterotomy and therefore lowered morbidity in cesarean deliveries during the second stage. We included women ages 18 to 50 with gestational age with a term pregnancy, 37 to 41 and 6/7 weeks, with a singleton pregnancy in the cephalic presentation, and only included nulliparous women. We excluded women that had a contraindication to a vaginal delivery, a prior cesarean section, the presence of a congenital fetal anomaly, and non-English speaking women. And patients who met inclusion criteria were approached on our labor and delivery during the first stage of labor. This was due to the fact that our institutional review board thought that it allowed women greater amount of time to consider whether or not they wanted to participate and didn't put undue pressure on them to be in the study. If the cesarean delivery was to be performed in the second stage, women were then randomly allocated to either the cephalic elevation device inflated group or the not inflated group. At the time of delivery in the operating room, the fetal pillow was inserted vaginally by the obstetrician after the Foley was placed and after a vaginal preparation with betadine, which is our protocol at our institution. And the delivery provider was blinded to whether the device was inflated or not. When they left the operating room to go scrub prior to the surgery, the group allocation was revealed to the anesthesiology team, who inflated the device to 180 milliliters of saline or not. Then the surgery went on as predicted. Following delivery, the circulating nurse accessed the device and either deflated the fetal pillow or carried out a mock deflation. And finally, it was removed by the delivering provider at the end of the procedure. The primary outcome that we measured was the time in seconds from hysterotomy to delivery of the neonate. And we use this as a proxy to distinguish the difficulty of delivery. And it was measured by the anesthesiologist in the operating room with a standard stopwatch. We collected a variety of secondary outcomes, including uterine hysterotomy extension and type, estimated blood loss, the change between pre-delivery and post-delivery hematocrit, blood transfusion, the total operative time in minutes, a composite maternal morbidity, with fever, DIC, ICU admission, and length of stay, as well as a composite neonatal morbidity score with birth weight, the 1 and 5 minute APGAR score, need for intubation, NICU admission, length of stay, and presence of fetal trauma. We also performed a survey to obstetricians to assess the ease of delivery and their opinions regarding the use of the fetal pillow. We thought that decreasing the delivery time by half would be considered clinically meaningful. And so prior to performing this randomized control trial, we performed a pilot study to look at the average time from uterine incision to delivery on our labor and delivery, and found that it was 41 seconds using 20 patients. And so we thought that it would be meaningful to decrease it by half, so to about 20 seconds. Setting a type 1 error of 0.05 and 80% power, assuming equal group sizes and a two-sided p-value, we determined that we needed 30 participants in each group to show a difference. And we intended to perform an intention to treat analysis. So for our results, this is a flow chart of our study inclusion. And so, as I mentioned, we consented women in the first stage of labor who were on the labor floor with term vertex singletons, knowing full well that many of these women would go on to have a vaginal delivery or a cesarean section in the first stage of labor. However, giving them the opportune amount of time to really think about whether or not they wanted to participate in the study. So as a result, the majority of these women were excluded due to, as I mentioned, cesarean delivery in the first stage of labor, vaginal delivery, or whether they or their providers declined. And then finally, we ended up with a number of 60 women who were to undergo cesarean delivery in the second stage. And so 30 were randomized to fetal pillow inflated, and 30 were randomized to fetal pillow not inflated. Of note, there was one patient who was randomized to the fetal pillow inflated group. However, when the fetal pillow was attempted to be inflated, the delivering team was unable to inflate the fetal pillow. And so due to the intention to treat analysis, that person was still included in the fetal pillow inflated group. And we had no withdrawals or loss to follow-up in our population. Looking at our baseline characteristics, women in the inflated group were a little bit older, but overall they were similar with their baseline characteristics. And in both groups, most women had a low transverse cesarean section, about 93% in both groups. And there was no difference in the length of the second stage or the fetal station at the time of delivery. Women in the inflated group had a higher rate of cesarean delivery for failure to progress, while those in the non-inflated group had a higher rate for non-reassuring fetal heart tracing. For our outcomes, our primary outcome was statistically significant, and we found that the median time from hysterotomy to delivery was lower in the inflated group, with 31 versus 54 seconds. And there were fewer extensions in the inflated group, though it was not statistically significant, as you can see here with a p-value of 0.05. There was no difference in estimated blood loss or transfusion, no difference in any of the other secondary outcomes, and no difference in any of the neonatal outcomes. However, these outcomes are quite rare, and so we were not powered to find those differences. The fetal pillow, as you can see here, based on our provider assessment, was very well received by providers. And providers in the fetal pillow inflated group reported that delivery was very easy at a statistically significant difference compared to women in the non-inflated group. So our study design, we think, had many strengths, with the main strength being that the study design itself, including it was appropriately powered for the primary outcome, and it minimized confounding with a double-blinded RCT. And also, we established a survey-based subjective data from blinded providers to really assess whether or not they thought that the fetal pillow was providing anything different for them. But like any study, our study is not without limitations, and our primary outcome was a process measure. However, we think that the time to delivery is considered a clinically meaningful outcome. And since while our study was done, there were a couple of publications produced that showed that the length of time from hysterotomy to delivery was associated with an increasing amount of time was associated with a decreasing cord pH score. And although several measures of morbidity were lower in the inflated group, we were underpowered to show these differences. And finally, in terms of generalizability, we only included nulliparous women at term, and so it's not necessarily generalizable to all populations. And so in summary, the use of the fetal pillow for cesarean deliveries in the second stage resulted in a faster time to delivery, is what we deemed. And what we're going to do now is have a discussion with two other providers at Brigham and Women's Hospital to get a better sense of what they liked about the fetal pillow, what they didn't like about the fetal pillow, and what has changed about our practice patterns here at this hospital as a result of this study being performed.
Thank you for that fantastic presentation, Dr. Lassey. Now, I would like to introduce you to two more speakers to the webinar. Dr. Julian Robinson, the Chief of Obstetrics of the Brigham and Women's Hospital, and Dr. James Greenberg, Associate Professor of the Harvard Medical School, who will be joining Dr. Lassey and Dr. Varma to discuss more about full dilation cesarean sections and their experience with the fetal pillow in practice. Thank you very much.
Okay, so just, we're talking about the situation where you have a deep transverse arrest. I think there's two scenarios. One is without any instrumentation, and the second is when you've tried instrumentation and you're going to cesarean section. So what do we have in our sort of clinical practice, or how do we address that situation? I would start saying historically, I think everybody, when they know they're going to a cesarean section, often in their last examination will push the head upwards, or even do that on the table with the cesarean section. But what are the other things that you can think of that we would go, or when do we plan to use a second level of intervention?
I think at our institution, the things that people use are now, since the trial was performed, the fetal pillow versus the putting someone in lithotomy and doing a hand from below versus putting someone in lithotomy and doing a reverse breech extraction. And talking to the various providers at our institution, I think people feel strongly about the way in which they like to perform these deliveries, and then typically do them in that method most often.
Yeah, no, I would use a mixture. I would say, so to me, the most important thing is remembering you have options, and not being in a situation where you're trying to get out a deeply engaged head and thinking, I wish I'd been better prepared. So to me, the questions are, is the head low or high? Am I worried or not? If I'm worried, we have the fetal pillow in the OR, so we can use that. If the patient's going to be in lithotomy, which for me is often the operative delivery scenario, nearly always with forceps, more usually OP, I'm going to keep the patient in lithotomy and just have an individual between the legs to do the hand from below. And we modify it a little bit by just dropping the stirrups down a little bit. And it seems to me having a low threshold for being prepared is a sensible thing. What did your practice do?
Well, I take it back even a step further. I think one of the problems with cesarean sections is we do so many as obstetricians that we tend to lump them all together. So we'll say, we're just doing a cesarean section, and maybe in our minds, we separate out the accretas as somehow being different. But I think all too often we get failure to progress, deep transverse arrest, breach, elective repeats as sort of one entity. And there's a tremendous lack of forethought about what am I going to do when I get into this situation. Taking an easier one, I think about repeat cesarean sections with unengaged heads. And they can be incredibly challenging with the unengaged head that's floating, and yet people are then often shocked. And they're running around, is there a coin spoon, is there a vacuum, are there forceps, tee up the uterus, do a breach. And so when we take that one step further, thinking about the arrest of labor.
Yeah. So
it's about preparation. I would say prior planning prevents poor performance, your 5 Ps.
Yeah, what I think you're talking about is actually the essence of obstetrics. Like the whole essence of obstetrics is having thought out all of the things that could happen and how you're going to deal with them, and they usually don't actually happen. So for instance, when I'm doing any C-section, I have a pair of Wrigley forceps in the OR, not opened, but ready there in case they're needed for the high head. So you have to think of all of the scenarios ahead of time and be prepared. And obviously with a deep transverse arrest or a deeply engaged head, you should be thinking about that and being prepared for it. For me, it's using the fetal pillow if we're not in lithotomy. If we're in lithotomy, I go for the person below, between the legs. I'm not a great fan of the reverse breech extraction. I've done one in my entire career and have never had to use it. What's your preference?
Well, it's interesting. I think when you look at the literature, there's certainly a movement afoot, no pun intended, towards reverse breech extractions. And I think that's all well and good. But like you, I've been now practicing obstetrics for 32 years, and I've only done a handful.
Yeah.
So it's not a skill that I think is beyond me, but I do think it's a skill that I'm not overly comfortable with.
Yes.
So now I have a deep transverse arrest, and I'm supposed to then do a reverse breech extraction when I haven't prepared myself. And so again, if that's going to be your go-to, then people need to start practicing it more, not in the difficult deliveries, but perhaps like times when it's not a difficult delivery and it's not an emergency. If you're not prepared to acquire that skill, then I think you need to think about alternatives,
Yeah.
whether they're head elevators,
Yeah.
or something like fetal pillow.
I think the issue with breech extraction, firstly, as you pointed out, is very hard to teach because you just don't do enough of it. So who's going to teach who? And the second thing for us was that when we did the randomized trial before this, the large one in India, they were using breech extraction as their first line when they were in difficulty. And they were finding that there was higher incidence of fetal injury, long bone injuries, particularly.
Long bone injuries, yes.
So they kind of wanted to give it up. And that's how they started doing the study on fetal pillow. And I think no matter how prepared you are, you will once in a while find yourself in a very difficult position, which with no amount of prediction, you will be able to resolve. And that's how, fetal pillow came about, because I had a patient in my hospital who baby died because of somebody trying to use their hand from below, and the baby died of skull fractures. But I agree with you that, you need to be prepared. And ideally, in my opinion, you've got to try and avoid the situation from happening in the first place. And I mean, I don't know what you think about it.
But it's worth mentioning also that I think it's common perception across the Western world that these difficult deliveries appear to be becoming more common. I found that just when travel, when I've asked other specialists, I thought it was a local thing for us, maybe related to length of training or greater number of providers or less experience. But it definitely seems to be a more common scenario than it was 20, 25 years ago when we were training.
I think 20, 25 years ago, we were attempting some difficult instrumental deliveries, which you don't want to do anymore. The rotational forceps has disappeared virtually. Well, I don't think in America anyone does it. In England, we still have a few hospitals who do it. And I remember we talking to Liverpool Hospital in England, who do a lot of rotational deliveries, and they teach their juniors. And they first said to us, we don't really have this problem. But in fact, they are one of our biggest users now. So it's, I think you may be right. The incidence is probably going up. Maybe the baby size is getting bigger, all sorts of reasons for it. I think epidural probably plays a big role, and US has got very high rates of epidural. I don't know, what is your epidural rate?
Our epidural rate,
In the study, it was like 98%.
it's 80, hospital-wise, it's 86%. And I was actually just talking to a colleague from Birmingham,
Yeah.
who does a database for all of the hospitals there, and it was 16% there.
No way.
No. Overall, that must be what, primates?
That was from the database. It's probably taking out all elective sections. It's probably just in labor.
Oh, that's incredible. That I thought it was probably around 48, 50%, but 16.
Yeah. Well, that was the figure that was shared with me.
Yeah.
The other thing to say is there have been other instruments that have come and go.
Yes.
There was the sea snorkel that was around for a while. I haven't seen that in a long time.
They took it off.
I've heard in the past of people saying before the sea snorkel, putting a Foley catheter down or a red rubber catheter down to release the vacuum. Sure. Everybody's very aware of the advice to lift up very slowly and in a controlled fashion.
Yeah.
But the point I think we're making is when we talk about trauma, that it's maternal trauma in this area, and that situation where no one wants to be in with the big extension down through the cervix and trying to stitch it up as blood's welling up and limited visibility.
Well, I think it's more than that, though. There's also hand from below. It's one of those simple things to do that is actually not that simple. It's a lot of pressure on the baby's skull. Yeah. Certainly a lot of depressed skull fractures.
Yes.
And so again, if there's something that's reasonably cost effective, that can prevent the problem in the first place, it seems like good value.
Yes.
I think especially, I mean, in this institution, we have multiple practices that are on labor and delivery. So there are usually plenty of people around that can help. But in many other places, there's one OB provider on call, or maybe an OB provider and a resident team. And they don't have actually the bodies to do a hand from below. And in that case, the fetal pillow is also potentially a good device because it alleviates anybody or a nursing staff that may not be allowed to do a hand from below. It alleviates that from being a barrier to the delivery as well.
I think that's such an outstanding point. We're blessed here to have fantastic resources.
Yeah.
I can, put my head out the door and have, 15 highly skilled anesthesiologists, a very robust blood bank, and in less resourced hospitals, even more so, you don't want to get into those very deep tears where you're sewing up blindly around the ureters, you're bleeding, you have an infant who's depressed. These are situations, again, prevention, an ounce of prevention, pound of cure.
Yeah. I mean, you now that you've finished the study and you are continuing to use it, have you got a criteria for using it, or are you saying use it in every full dilation cesarean sections?
This has been discussed kind of at length, and we still leave it up to the provider to decide whether or not they want to use it. We've tried to make it as easy for the provider as possible to incorporate if they would like to incorporate. They're included on kind of the prep table in every operating room where the vaginal prep is included and the scrub prep for the abdomen. There is a fetal pillow there if that provider wants to use it. But I would say that especially among certain practices, there's been a significant increase of use since the study reported.
Yeah. I mean, that sort of mimics our experience with people using it. Once you've used it 2 or 3 times, you kind of feel that it makes my life easy. Why not? And I think most physicians feel like this, and I suspect it's going to be the use will grow slowly with other physicians talking to each other. I mean, you've had, I know we talked a bit about your trial. You had one patient where it failed to inflate, and we never really found out what exactly was the reason for it.
So and you've seen it obviously, but if you look at the fetal pillow device is like this, and the straw part that is used to inflate it comes out the posterior aspect. And when it's inserted, you want it to go flush against essentially the sacrum and then along the baby's head.
Yes.
They had tried to place it after talking to the provider upside down, so that the straw part of the tubing was kinked.
Okay.
And so it was unable to be inflated.
Yeah, I mean, that is a common thing, even though we keep telling people that the tubing should be facing upwards when you put it in. But, doctors are very bad at reading instructions.
I never even knew anything came with instructions. I thought we had to figure everything out. Now you tell me there's instructions. Who knew?
But it was the only one in the whole group.
Yes. And I think it's a relatively simple device to use, but you will still get occasional physician where, there are difficulties. And
but I think it's one of these things, like we thought about it a long time ago in this institution. We thought about having a checklist for C-section, and so it's exactly what Jim was saying earlier, so the thought should be, is the placenta anterior? Am I going to be going through the placenta? What's the hemoglobin? What's the hematocrit? Do we have a lot in the bank? The next thing should be, is the head going to be difficult to deliver? Do we need to be thinking about that and preparing before we start the cesarean section?
But you haven't got that checklist yet?
We've got lots of checklists.
I can imagine that. I mean,
you do get a bit of checklist fatigue. But again, I think this just comes also with time and experience.
So true.
It becomes more of a natural process. But I think that's, as I said earlier on, one of the hazards of cesarean sections is it's the lull of they're all the same.
Yes.
And if you believe that, I say to all of it makes all of our interns crazy. It makes everyone crazy. But I would say there are exactly 2 ways to do a cesarean section. There are only 2 ways: the right way and the wrong way. And the wrong way is the way you were taught. And the right way is where everything you do has a purpose and a reason.
Yeah.
So if every decision that you're making along the way, why am I doing this? There is a reason why this suture, why this instrument, why this cut here, why this clamp. And to do the same thing for every cesarean section, to me, is incorrect. You have to kind of you have to tailor your procedure
Of course, yes.
to the clinical scenario.
Yeah, and that applies to virtually every operation, I suppose, to some extent. Yes, yes.
Yeah. But it's difficult in obstetrics because I think often, no matter what we do, the outcomes are very good.
Yeah.
So we can be lulled into a sense of
security,
attention to detail
Yeah.
really doesn't matter.
Yeah.
And often people are discovering, in the worst of times that it does matter.
Yeah, no, I agree. Yes, I think. I mean, I don't know. There's anything else you can tell us about your experience of using Fetal Pillow? I mean, Sarah, you must have used a few by now.
Yeah, I mean, I was obviously involved in the study and then have used a few since then. I think overall people find that it's very easy to use and just very user friendly. It's quick to put in. I think it's made, it doesn't make every delivery like the easiest thing in the world, no, but as you said, they're going to be hard deliveries. But I do think that it has been well incorporated.
Yeah, I think so. Probably the summary statement from the quality and safety side is I've heard of people regretting not using it. I haven't heard of them regretting using it.
Well, thank you for our speakers for that insightful discussion. I'd like to thank them particularly for their time today. It is evident from the discussion that full dilation cesarean sections are a challenging delivery that carries increased morbidity for both mother and baby. As these cases have increased over the last 20 years, they are no less challenging a delivery. And one key element from the discussion was the importance of planning ahead and being prepared for what you're going to do to deliver the baby and why. In these most difficult of cases, Fetal Pillow provides physicians with an additional tool to support the delivery of the baby, to help reduce difficulty and increase safety. I would like to thank you all for participating in our webinar today, and thank you again to our speakers, Dr. Lassey, Robinson, Greenberg, and Varma. Thank you very much.